So let's look at these diabetic emergencies. It mentions altered mental status first. We got some Khan Academy stuff with the diabetes. He does a great job of explaining insulin and sugar production. So I just go off him, use that. It's much better than the pictures that I have. His drawings are. When we look at altered mental status, there is an array of things that can cause an altered mental status. And altered mental status is something that is very popular EMS-wise. You could have diabetes, seizures, hypoglycemia, drug-induced, alcohol-induced, oxygen deprivation, all these different kind of things that would cause you to have altered mental status. The biggest thing here that you look at is this RAS, this reticular activating system. And just like it says, it is responsible for us staying awake, staying conscious and alert. And the thing with it is, it's located in the center of the brain. So when someone has an altered mental status or they're knocked unconscious and it disrupts this RAS, it's essentially telling you the core of the brain. So anything that's really tucked away inside is very important, like in the body. The heart's behind all the ribs and the sternum, so is the lungs. All your vital organs are behind the rib cage. Your liver's tucked up underneath the rib cage. It's well protected. The brain is surrounded by bone, right? It's protected. So when we start talking about this RAS, we're talking about something that is vital, and it disrupts that, causing an altermentation. Our goal is to figure out why, right? Why do they have this altered mental status? What keeps them from being alert to person, place, time, and event, correct? So that's what we'll just unpack as we go through. One thing is oxygen. Probably in trauma patients, cerebral hypoxia, brain injury, brain swelling. We get a lot of head trauma, head injuries, strokes the same way. Glucose, we always have to have glucose. We burn glucose nonstop, 24 hours a day. Without it, the brain shuts down very quickly without glucose. So and also water, we got to stay hydrated. So there's several things there that could cause a balance. Any of you guys ever heard of water toxicity? Mm-hmm. You ever had it? Mm-hmm. What do you think water toxicity is? Can you drink too much water? Yes. What is drinking too much water? What does that do to the body?
It makes it gets rid of the salt levels.
Right, exactly. It depletes your sodium levels. And you become hyponatremic or hyponatremia, and that causes big time problems with the electrical system of the heart. What are the elements, what are the ions that we use for muscle contraction? Potassium? Sodium? Let's start with the C.
Carbonate. Corn.
Calcium?
It's because I started it and you were looking at me and you looked away, so I thought I was wrong.
Alright, so
I didn't ever hear you.
the disruption in sodium, potassium, any of the electrolytes will cause muscular problems, cause contractile problems in the heart, right? High or low, so you have all these different requirements of the body to maintain a normal mental status. So we look at what takes place, trauma, infection, you get too hot, get febrile. Fever causes an altered mental status. Has anybody ever seen one just with the high temperature that has, like they're talking out of their head and they're all crazy? Maybe you've been there. Yeah. So fever will do that as well. Get these toxins going. Stroke, asthma, hypoxia. So there's quite a few different things that will cause it, what we do in our treatment is we start ruling those things out. How do we rule out hypoxia? I mean, how do we fix it? We think that's the problem. How do we fix hypoxia? Oxygen. Give them a non-rebreather, right? Let's put a non-rebreather on them. We know how to fix glucose. Let's say it's a glucose problem, right? Give them more glucose. Check their D-stick, give them more glucose. Anybody with an altered mental status, you need to do a D-stick, a dextrose stick. Anybody with an altered mental status. So, if that's the rule, if we say the rule is everybody with an altered mental status gets a D-stick, so you pick up the patient from the nursing home, the nurse tells you, hey, this person's normally altered, this is her normal mentation, she's like this 365 days a week. What do? Right, you give them a D-stick. Yeah. Week, right? That's a lot of days in a week. So, yeah. Even when the staff tells you, yeah, that's normal for them, always do a D-stick. Because you deliver the patient to the hospital, they have an altered mental status, what are they going to do? Yeah, they're going to do a D-stick. Just always do that. That will keep you safe and out of trouble. So, one thing they can be, even patients with cerebral hypoxia can be very violent. So make sure, especially in also patients with hypoglycemia, they can be extraordinarily violent. They're not meaning to be, it's just a reaction to the lack of oxygen or the lack of glucose. You give them oxygen, you give them glucose, most of them are nice people, right? They get very violent, so make sure that you're safe when you're there. Someone with hypoglycemia, they may still be violent, but you have to deal with that, right? So you're going to have to restrain them, try to get some glucose in them, or treatment. But again, you want to make sure it's safe. Maybe you bring law enforcement in to help you restrain them.
Could you just sit on them and put it on the throat?
Well, what's one of the requirements? They have to be for like oral glucose. Conscious and...
I mean, like if they're trying to fight with you and stuff, like...
If they're trying to fight...
I mean, not like necessarily fight, but like they're squirming around, like they won't sit still. Could you just like sit on them and squeeze it into them?
It's probably not safe, because then you don't know if they have the ability to swallow or not. We've had to hold down several older ladies, geriatric patients that are beating us up, and try to get an IV to put in some D50. I'm glad there wasn't any video cams, because you have 4 or 5 firemen laying on Granny trying to hold her down, and someone sticking her with a needle. It just doesn't look good to the public. But sometimes it's necessary to restrain the patient so you can do the treatment. So you would have more difficulty with oral glucose with that. So always consider oxygen as being part of the problem. Maybe they're just not, they have some hypoxia. So just like any assessment, always assess life-threatening injuries or illness. Give them the oxygen just to rule that out. All right? And then they might be vomiting, nausea, vomiting. May not be able to tell you that. If their mental state worsens, they may not be saying, hey, I'm about to vomit. They may just vomit. So you may have to make sure that you got the patient in ready to suction or at least in a recovery position. Even these older ladies, geriatric patients, man, they can be brutal as far as being able to take care of them once they get, especially with hypoglycemia, or they get an altered mental status. So one thing that you want to know that you might have to start doing is asking bystanders. If they have an altered mental status, they may not be able to give you all the information, right? So you may have to rely on other people to help you along the way with the information that you're going to need, like your sample. Make sure that anybody with an altered mental status, you do a complete exam on, that you don't leave anything out, that you're covering all your bases. Get good baseline set of vital signs. Get a good baseline mental status, because you're going to try to treat them, preferably with oral glucose or oxygen. So you'll need to know what they were like before, right? Get a good baseline in order to see if they're any better. Most of the time that's obvious that they're better. They start answering your questions. Family members are a very good source. They can tell you if this is normal for the patient, abnormal. Neighbors, ran on people who, lady sitting outside her house just screaming and screaming. And so we had to rely on their neighbors in order to say, is this normal for this person? They said, well, no, it's very abnormal. So we did a D-stick and she was hypoglycemic. Once we gave her some sugar, she stopped screaming. But for some reason, the hypoglycemia just caused her to scream and cry all the time. Couldn't quite figure it out. But through a process of elimination and the help of the bystanders, we were able to figure it out. Also, the patient's medications. You start looking at the patient's medication. Anything with GLY in it, GLY in it, is a diabetic medicine. So if that is in there somewhere, you can suspect diabetes. If you see syringes all over the house, they're either a junkie, a clean junkie, or a diabetic, right? So you have to start sort of looking at all the stuff that's around you and picking up clues. The other thing is some people wear the medic alert bracelets or necklaces. So you start looking for them. Anything that's going to give you a clue on what's taking place. That's why it's very important to be observant. Right? It keeps you healthy for one, but you need to be observant in order to pick up the finer clues. All right, so let's look at diabetes for a little bit. And Con's going to help us with that. But talking about glucose and insulin.
Every cell in the human body needs energy to survive and do its different functions. If we're talking about a brain cell, it needs energy to keep stimulating other brain cells and sending on signals and messages. If it's a muscle cell, it needs energy to contract. They need energy just to do the basic functions of a cell. And the place that they get that energy from, or the primary source of that energy, is from glucose. Glucose. And glucose is a simple sugar. If you were to actually taste glucose, it would taste sweet. And glucose gets delivered to cells through the bloodstream. So this right here, I'm drawing some blood that's passing by a cell. Maybe the blood is going in that direction over there. And inside the blood, let me draw some small glucose molecules passing by. And so in an ideal situation, when the cell needs energy, glucose will enter the cell. So glucose will enter the cell. Unfortunately, it's not that simple for the great majority of cells in the human body. The glucose won't enter by itself. It needs the assistance of a hormone or a molecule called insulin. So let me label all of these. This right here is glucose, and it needs insulin. So let me draw insulin as these magenta molecules right over here. So that over there, that is insulin. Insulin. And the surface of these cells, they have insulin receptors on them. And I'm just drawing very simplified versions of them. Kind of a place where these magenta circles can attach, can bind. And what happens is in order for the glucose to be taken up by the cell, insulin has to kind of attach to these receptors, which unlocks the channels for glucose. In order for the glucose to go in, insulin has to bind to the insulin receptors. And then once that happens, then the glucose can be taken up by the cell. Now, unfortunately, things don't always work as planned, so let me draw a couple of scenarios here. So once again, let me draw my very simple version of a cell, and let me draw the bloodstream going by right over here, and then let me draw the glucose in the bloodstream. So I have my glucose floating by, and then I have my insulin receptors on the surface of a cell. Now, the first thing that could go wrong here is, what if the body does not produce insulin? Insulin is produced in the pancreas. What happens if the pancreas is not producing insulin properly? So no insulin. Well, in this situation, since there's nothing to bind to these receptors, the glucose channels won't be opened up, and the glucose will not be able to enter into the cell. And this situation is type 1 diabetes. Type 1 diabetes, where you've got glucose, so in theory you have energy, and you have properly functioning insulin receptors, but you just don't have insulin to kind of unlock the gates for the glucose to actually go into the cell. The other scenario that you could imagine happening, let me draw the cell again. So there's my cell, and let me draw the blood flowing past the cell. And once again, obviously, this is just one of trillions of cells in the human body. We have an estimated 10 to 100 trillion cells, so this is a very simple diagram, but hopefully gets the point across. So once again, let me draw some glucose floating by. Let me draw some insulin receptors on the cell. So insulin receptor there, maybe insulin receptor right over there. And let's say we even have some insulin. So our pancreas is producing insulin and putting it into our bloodstream, so it's there to be used. But a situation can arise where the receptors are not working properly, or we become insensitive or desensitized to insulin. So desensitized receptors. So in this situation, you have sometimes maybe it might be the insulin is hard to bind, or even if it does bind, it's not working properly, so the glucose will not enter the cell. And so in either one of the, I already wrote desensitized. So in either one of these scenarios, let's just think in a very broad level, I'm not going to go to the details of the actual therapy for these diseases, of how it can be cured. Oh, and I didn't even name the second one. The second one right here, as you can imagine, if this up here is type 1 diabetes, this down here is type 2 diabetes. Type 2 diabetes. Now, the simple way that, or I don't want to say it's necessarily simple, but the way that you can manage type 1 diabetes is you can inject insulin. The only problem here is, it's a big one though, is that there's no insulin in the bloodstream. Everything else is working properly. So over here, we can inject insulin. We can inject it. And then you'll have insulin to attach to the receptors, and then the glucose can be processed properly. Type 2 diabetes, there's kind of multiple lines of attack. One thing that you can do, there are actually drugs that attempt to kind of resensitize your insulin receptors. You can also do that with a combination of lifestyle changes that makes your body, more sensitized to sugar. Or you can even, if things get severe enough, you can add insulin, just like you would do in type 1 diabetes. And you can say, wait, I already have insulin here. Why would I add more insulin? Well, remember, we're not the cells can process insulin, but they're desensitized. They would need more insulin in order to kind of uptake the same amount of glucose. So if you add insulin, you could possibly have enough of a trigger that the glucose can actually be taken up. But there's multiple lines of attack here, and usually the first one are giving drugs that hopefully make resensitize you or make you less desensitized to the actual insulin. And so the last thing I just want to think about a little bit is, well, what happens if you didn't do this? Well, there's two major problems here. Obviously, your cells can't function if it's not taking up glucose, so your cells will have no energy. And another problem, if you weren't to manage either one of these types of diabetes, is that sugar, once it gets to if it gets to high enough concentrations in the blood, it can actually cause a lot of damage. So sugar can cause damage to the body. So you don't want either of these things happening. You want your cells to have energy, and you don't want to have too much sugar flowing in your blood and causing damage to your body.
Okay, so very good explanation. So essentially, type 1 diabetics have to take the insulin. They don't have, their pancreas doesn't produce the insulin that they need. Type 2 diabetics usually can control their diabetes with oral medication or diet. So, if I went to the doctor and they say, man, Randy, you're just eating way too much Bluebell. Look at that gut. You've got to lose some weight, and your blood sugar is shooting through the roof and all this. They're saying if you don't stop what you're doing, then you're going to develop diabetes. All right? So that'd be one way to do it. The most common one that you will see pre-hospital-wise is the type 1. The type 1 diabetic usually either eats too much, doesn't take enough insulin, doesn't eat enough, takes his insulin, drops his blood sugar. So there's several different combinations in there that you can see, but type 1 diabetics are usually the ones that you have to manage. And we will look deeper into that in a little bit. We'll look more into diabetes in just a second. Con has a couple more videos here which talks about the blood sugar and the blood sugar levels.
Let's think a little bit about how we can tell whether our body is processing glucose properly and whether maybe we have diabetes. And I want you all to take all of this with a huge grain of salt, because I am not a doctor. This is not medical advice. My goal here is to kind of just explore the subject with you and to try for all of us to get a better understanding of things. So let's think about what might happen after we have a meal. So let me draw a little chart over here. So let's call this hours. And then on the vertical axis, I'm going to talk about our concentration of sugar in the blood. So blood sugar concentration. Blood sugar, or actually you could call it glucose concentration. Blood sugar concentration. We're talking about blood sugar, we're talking about glucose concentration. Now let me draw a couple of points on this chart. So maybe this is 50, and our units are going to be milligrams per deciliter. And actually, let me just do it this way. Let me just say that everything is in milligrams per deciliter. And we'll talk in future videos about, what kind of, how we can relate these units to everyday terms. But let's say that this right here is 50, this right here is 100, this right here is 150, and let's mark it right here at 200. So let's think about what would happen for a normal person. Let me mark some hours over here. So hour 1, 2, 3, 4, 5, 6, 7, 8. That's probably good enough. So a normal person, when they haven't eaten anything for a long time, let's say greater than 8 hours, so their fasting blood sugar will be right around 80 milligrams per deciliter, give or take a little bit. There's a range around that, but I just want to show you what would happen to a normal person. So at 80 milligrams per deciliter, their blood sugar will kind of should hopefully be right around there. And sometimes this fasting blood sugar, and maybe we're assuming that this is in the morning, so maybe this hour 1 is 7 in the morning, so they haven't eaten for a while, that's why it's fasting blood sugar. This is also, you'll hear, and you'll sometimes hear doctors, I've heard my wife say this word without knowing what it meant, they'll sometimes say preprandial, which is a very fancy word, which just means before a meal. Prandial is literally before eating. After the meal, you're talking postprandial, so it's a very fancy word for a very simple idea, eating. So let's say at hour 2, this individual eats breakfast. So this is where the individual is going to eat breakfast. Now in a normal person, when that person eats breakfast, there will be some carbohydrates in that breakfast, and it will be broken down into glucose, and that glucose will enter the bloodstream. And so their blood glucose will go up. Their blood glucose will go up. It'll slowly go up, and I was reading some studies. They say it kind of spikes at about 45 minutes into a meal. So let's see, 45 minutes is over there. So maybe it'll go up to about there. And in a normal individual, the blood glucose really shouldn't go up above 120 milligrams per deciliter. And there's obviously exceptions to all of these. We're just kind of saying the normal breakfast, the normal person, they're not eating a pint of honey. They're not doing something crazy. So let's say 120 would be right around there. A normal person, someone who does not have diabetes, it would be unlikely that it would go above that. And then actually after about 2 hours, they're getting pretty close to normal. They get back under 100 milligrams per deciliter. And then you go beyond 2 hours, they just kind of get close back to their baseline, to that 80 milligrams per deciliter. So once again, this is normal. And of course, don't freak out if you were to take a blood test one morning and you were at like 85 milligrams per deciliter. You're still not far off from normal. So obviously there's some variation from person to person. Now, if someone has diabetes, if either they have type 1, they don't have enough insulin to actually process the glucose, or if they have enough insulin, but their body is desensitized to it, the insulin isn't being processed properly, so they can't process the glucose, we see that the glucose concentrations will go up. And so in general, if you were to wake up one morning after not having eaten for more than 8 hours, and you were to prick your finger with one of those little glucose monitors you can get at the drugstore, and in your finger, the blood sugar levels, if you were to find them to be, let's say you were to find them to be at 100, let's say 140, that's 140 milligrams per deciliter. It's a good indication. I mean, you shouldn't freak out. You should do multiple tests and make sure that it wasn't a false reading or any of that. And you should definitely see a doctor. Once again, don't view this as any type of medical advice. That is not the purpose of this. The purpose of this is just to understand a little bit of what's going on. Don't change your lifestyle based on anything I tell you. All right. So if you do experience that, it looks like, at least just from that one data point, that your body isn't processing sugar properly, because you've had over 8 hours to process the sugar for insulin to go in your bloodstream and allow glucose to be taken up and get back down to a normal level, but it still hasn't gone there. So if you were to test a value like that, you should be concerned. In general, the threshold, and I've seen multiple thresholds here, are between 100 and I've seen high, kind of mid-120s to 130 milligrams per deciliter. So that's kind of, let me do it in this range. It's kind of if your fasting blood sugar is above this line right here. Remember, the fasting blood sugar, not after you've eaten a meal. Your preprandial, before a meal. If it is above that threshold right over there, then you should definitely see a doctor and make sure that they can see if you have diabetes. But this would be cause for concern. Another thing is, it's after a meal, it spikes well beyond that. If it gets above 180, and once again, these are all just thresholds that doctors have come up with and researchers have come up with that say, hey, this is a good indication that somehow you are not processing glucose properly. So 180 is up here, and I'm drawing it as a squiggly line because it's kind of a range. It's not like if your blood glucose is 124, you're safe, and all of a sudden at 125 you have diabetes. No, they're not that different than each other, but they have to set up some threshold so that just to kind of have a threshold, I guess. So if your blood sugar after eating a meal were to spike up to, let's say, 200, once again, that would be cause for concern. So in general, if someone has diabetes, because they're not processing the glucose properly, their blood glucose might look something like this. So maybe their fasting blood glucose is right around 125, 130, can move around. Then they have a meal, then it might spike up. They might have, obviously they can process some of the glucose, otherwise they would die, but it's not being processed properly. So the glucose levels don't go down to where they should, and maybe you get some glucose gets taken up from the blood. Obviously they're living, so their cells are metabolizing something, but it never gets down to the normal 80 milligrams per deciliter. It might settle down back to something in the 120 range or something like that, which would be cause for concern. And in general, if you're someplace, I've seen the threshold, if you're above 100, and on a fasting basis, that's cause for concern. You should maybe adjust your lifestyle. And if you're above, if you're above 120, 130 after a meal, once again, you should also be slightly worried that you might maybe are pre-diabetic or you have some risk of developing diabetes. So this is a high. If someone has blood sugar like this, they're probably diabetic. And if someone has blood sugar like this, they should be worried. But once again, I am not a doctor. Don't take any of this as advice. This is really just our attempt to understand things a little bit better.
Of course, he is right with that information. The way that they check, if you think you're having trouble with your blood sugar, you're always having headaches, you're nausea, vomiting, you're urinating all the time, you're always thirsty, you have these sort of precursors to diabetes, and they're looking at that, and what they do, the doctor will call you in and say, hey, fast all night, come in the morning, we're going to draw some blood. So you fast all night, just like he said, you go in the morning, they draw blood, they do a blood glucose on it, and if it's like that, if you have a high fasting, whatever that big word he used was, fasting blood sugar, then more than likely they're going to start treating you for diabetes. And if your blood sugar is really high, then for sure they will. So they'll start in that range and they'll start watching you and laying out a treatment plan for diabetes and trying to figure out which one do you have. Do you have type 1 or type 2? And do more tests. What kind of doctor would do that? The specialist, what is he called? Besides Filthy Rich? An endocrinologist. That's it. Endocrinologist deals with the endocrine system. Diabetes is an endocrine problem. So he does lay out a good definition on how that blood sugar works. All right, let's got one more short one, and then we'll.
In the last video, we saw how blood sugar concentration or glucose concentration in your blood of 80 milligrams per deciliter, 80 milligrams per deciliter, was kind of a normal fasting blood glucose if you hadn't eaten for 8 hours or before a meal. And the fancy word we learned in the last video was pre-prandial. What I want to do in this video, because 80 milligrams per deciliter really doesn't make a lot of tangible sense to me. I don't know exactly how much sugar that is. What I want to do is try to put this into different units so that we can better conceptualize how much sugar that might be in our body. So let's just do a little bit of unit analysis over here. So if we have 80 milligrams per deciliter, that's what we're talking about. That's a normal fasting blood glucose level. Now let's think about how much that is per liter. A deciliter is a tenth of a liter. So if we want to cancel out the units, we want deciliters. We have deciliters in the denominator here, so we want another deciliter in the numerator. So we want to know deciliters per liter, because then that and that will cancel out. And there are 10 deciliters per liter. There are 10 deciliters per liter, and so that gives us 80 times 10 is 800 milligrams. 800 milligrams per deciliters cancel out, milligrams per liter. Now if we want that in terms of grams, we can just multiply. We want to get rid of this milligram, so we want that in the denominator. Milligrams, we want grams per milligram. 1 gram is 1,000 milligrams. So once again, milligrams cancel out, and then you have 800 divided by 1,000. So 800 over 1,000 is 0.8 grams per liter. Grams per liter. Let me start over here. So we have 0.8 grams per liter. And then to make sense relative to a normal human body, I looked this up on the internet, the average human body, so I'm assuming I'm like 5'9", 150 pounds, so I think I'm pretty close to average. But they said the average human body has about 5 liters of blood. So let's multiply this times 5 liters per human. per average human. Obviously, a small human will have less, and a very large person will have more blood flowing through them, but this is an average person right over here. So then we get the liters cancel out, and so we get 0.8 times 5. 8 times 5 is 40. 0.8 times 5, we're going to have one decimal place. It's going to be 4. 8.8 times 5 is 4, and then we have grams per human. 4 grams per human. And just to get an idea of what 4 grams are, 1 teaspoon is equal to 4.2 grams. So 4 grams is almost a teaspoon. So it's approximately 1 teaspoon of glucose per human being. So in your entire bloodstream, you have about a teaspoon of sugar that your cells can use to do whatever cells need to do.
That's pretty cool.
That's not a lot at all.
Now, that's not much glucose, but glucose is, I mean, it's not a lot of glucose, but we use it efficiently, I guess, like everything else. Say what?
We use it as we need it.
Yeah, as you need it. And then it just floats sort of in the bloodstream. You can't have a lot of free-floating glucose like we talked about, like Con talked about. It causes a lot of problems. One, it causes huge problems in the kidneys. It causes renal failure. If you look at a lot of diabetics who are not controlling their diabetes, they're also renal patients. They're in end-organ renal failure. So you'll see that as you go through. You'll see patients on dialysis, they have hypertension, and they also have diabetes. So let's look at these 2 diabetic emergencies. They're fairly simple. Once you sort of get through the whole glucose use, one thing that Con didn't mention is it's called the ability for the cell to uptake the glucose is called active transport. And active transport just means that it needs help. So it needs the insulin to bind with that receptor site to open up the cell in order for the glucose to be able to go into the cell.
How do people get diabetes? Is it genetic?
Yeah. A lot of people are predisposed to diabetes. Like Hispanics are greatly predisposed to diabetes.
So you can't just get it?
You can, yeah, you can develop diabetes. Poor eating habits. Like he's saying there, he's talking about changing your lifestyle. He's mainly talking about changing the amount of sugar that you eat, controlling your input of carbohydrates. So, I mean, if you ate pizza every day, and eat, your diet consisted of a large pizza and a pint of Bluebell every day, then hey, you're predisposing yourself to diabetes, and you didn't work out, and you retained all that sugar, or all the drinks, all the sugar water that we drink, the Cokes and the Gatorade and all that. If you ever didn't drink any water, then hey, you're building up this blood sugar, this glucose is floating in there, and you have an excess of it, and then that's where you're going to get into saying, well, you're leading yourself into to be a diabetic. So let's look at this: hypoglycemia, hypo-low glycemia. But when you look at the majority of diabetic cause, it's hypoglycemia. You're going to do the D-stick. You're going to do what you need to do there. So you're going to do a D-stick, but most of the time it's going to be hypoglycemia. Hyperglycemia can occur, but it's a slower onset. So when we look at hypoglycemia, that's going to be a very quick onset. In hyperglycemia, it's going to be gradual over a period of time. Now, the diabetic could be either or. All right? So that's why we check the blood sugar. So hypoglycemia, the diabetic takes too much insulin. He takes too much insulin, and it breaks down the insulin in the body too quickly, and you don't have enough insulin. When they exercise, they start to vomiting. Diabetics have to be very careful of getting sick and vomiting or diarrhea. They can lose too much blood sugar. Too much glucose, and their blood sugar will drop. The majority of patients that you will encounter, that I've encountered, is in the morning, they went to sleep, they took their insulin, forgot to eat, or they forgot to eat dinner, or they worked all day and were tired and they fell asleep and didn't wake up. And so they, wife or family wakes them up, can't wake them up. They got this fruity odor smell all over them. And they know, the family knows, either call EMS, they forgot to eat or they took too much insulin. You get there and you give them the sugar, check their blood sugar, give them sugar, wake them up, and like, oh yeah, I forgot again.
Can families just like give them sugar? Or does it have to be oral glucose?
Well, the problem is the majority, a lot of times, and this is where you guys are going to be a little restricted, is when you get the hypoglycemic patient, the majority of the time they're too altered to give oral medicine to. So they have to have ALS to come out there and start an IV and give them IV glucose, D50. And it wakes them up quick. You give the D50 and you wait, a minute or so, and they start to wake up. And it's funny because they'll wake up and they start looking around and go, ah. And they know instantly while you're in their bedroom. They forgot to do something. So the majority of the time you give them the D50 and they say, yeah, thanks, I'll eat breakfast. You pull the IV out and go home. You don't even take them to the hospital. They know what they did wrong. They need to get up and eat. And it's just a mistake. You have other diabetics who just won't control their diet. They know they can't eat that gallon of Blue Bell. That's going to jack them up. But they go ahead and do it. And they're just, and that term is called non-compliant diabetic. And those are the guys that you see with no feet or legs. Because diabetes destroys the neurofibers in the extremities. So they start losing their toes, they start losing their feet, it just works its way up. They can go blind. So a lot of things. So if I ever become a diabetic, then I'm going to control my diabetes. I'm going to still eat the ice cream, I'm just going to take extra insulin. But, so all these things can be causes of hypoglycemia. These are the things that you look at. The treatment is fairly easy. Very rapid onset, abnormal behavior. They do act like they're intoxicated. If they're conscious, man, they're just, a lot of times just very violent. But don't let that get to you. That's just them. That's just the hypoglycemia in them. Pale, sweaty. They can start having seizures from it. This is sort of a last stage that you get into, a diabetic seizure where their blood sugar is so low that they're starting to seize. But the treatment, you get out there, you think, I got a diabetic patient, you prick their finger, get a blood glucose, low glucose. If they're alert enough to take the oral glucose, then you just give them that. Now, that's going to take a little bit more time than the IV glucose, right? So you're going to be sitting for a little bit if you're giving them oral glucose. I've given oral glucose quite a bit, and it usually takes 10 minutes or so for their blood sugar to come back up. So you may have to sit a little bit longer there with them. Once you get their blood sugar back up, you need to make sure that they eat. Because what will happen is their blood sugar will spike because you just gave them a bunch of sugar, right? You just gave them a bunch of that oral glucose, or D50. It will spike. It will go from, let's say, 40 to 300. But their body's going to burn that glucose off quick. And if they don't eat a good meal, big, meaty carbohydrate meal, just a regular meal, their blood sugar's going to fall back again. They're going to rebound, and then they're going to be hypoglycemic again. So they've got to eat once you give them the medicine. That's something important pre-hospital-wise. You're in their house. You want to make sure that they have the ability to eat. You want to look around, do a little investigation. Ask them, can you cook? Do you have food? There's a lot of people out there that they get hypoglycemic and they fall right back because they don't have food. So you've got to make sure that they have the ability to eat.
What if they don't?
Well, if you don't take them to the hospital, they wake up, they come times 4, and they refuse to go to the hospital. They don't have you see that they don't have the ability to eat, then you need to call somebody. Okay. a lot of the ambulance crews would go get them some food. You know, you've been in their house, you're looking around going, you haven't eaten in a while. You know, I don't see any food. And it's quite a hard conversation to get into with an adult, right? Older adult. And so, you know, you go out and get them a hamburger or something. That way you don't have to go back and treat them again. Because if you don't, and then you make sure you call Adult Protective Services so they can go out and make sure that they're taken care of. Because I know it's in your young world, you're not used to people not having nutrition and someone to take care of them, right? Because there's a lot of people out there like that they don't, their family has, you know, jumped ship. They don't have any family, they don't have a job, they don't have means to eat. So when you get into something like that, as a provider, you know, it's not your responsibility to provide food for them, but you want to make sure that they're taken care of. So you can notify the police or Adult Protective Services. So because that happens quite a bit. At the hospital, if you take them to the hospital, they're going to feed them. And then you would mention to the hospital, say, hey, we were in their house and I don't think they're well taken care of. And then they would contact Adult Protective Services there. So the result of the hypoglycemia, no glucose to the brain cells, they get this very quick altered mental status, leads to unconsciousness, and if they're without glucose too long, they can either have permanent brain damage or death. And that'd be the worst way to die, just your brain starving itself to death, correct? I mean, I can't think of too many worse ways to go than like going some sort of hypoglycemic coma and your brain just eating itself from the inside. Or I can think of something worse is you get in that permanent brain thing and then someone comes along and gives you glucose. And now you're essentially brain dead from it. All right, any questions on hypoglycemia? Everybody good? Hyperglycemia is just the opposite. You have too much sugar, too much glucose. All right. You may have increased your diet, which that is number one. They eat too much. They don't take their insulin. They don't take enough insulin. For some reason, their blood sugar is becoming much higher. Like you said, it's a gradual, develops over days. Sometimes it's you get the 3 P's of diabetes through here. The first P, poly. Everybody understand what poly means? Many, right. So polyuria. Urea would be urine. So excessive urine. Polydipsia. Heard that word before? What would dipsia mean? Remember, they made up these words a long time ago. Where when you get to water, you dip water out of a well. Not like the back. Yeah, very thirst, excessive thirst, and polyphagia.
Excessive hunger.
There you go. Now you're speaking up. I can hear
I
you.
said all three of those.
Well, I can hear what you're saying.
What was the last one? Excessive what?
Excessive hunger. Then with this, you also get that fruity odor smell to the breath. The body's trying to get rid of the ketones that it's producing. The nausea. One thing that hyperglycemia causes is dehydration because of the excessive urination. Become very dehydrated. We don't give insulin pre-hospital, so really the only thing that you would do for hyperglycemia is just primarily EMT-wise is supportive care. ALS-wise is start an IV and give them a lot of fluid. Start replacing that fluid that they lost. The worst result here is what's called DKA, diabetic ketoacidosis. Keto means that they're producing the ketones that we talked about, that not only do they try to get them off with respirations where you get that fruity odor, but also they start urinating the ketones out. The kidneys do not like the sugar, the protein in the urine. That's always bad. But the worst thing is the acidosis. It changes because of this. You're hanging on to all this blood sugar. It changes the pH of the blood, and the patient becomes acidotic. So now they have a big problem. They're producing these ketones, and then they're acidic. So you have to. This requires advanced life support. This is going to require someone give them a lot of fluids, and possibly even giving them sodium bicarbonate. Because we know that the body, right, has bicarbonate in it. This is the way, what's the normal blood pH? You're right. 7.35 to 7.45. It's the normal blood pH. What happens is acidity, you're going towards 7, right? So the blood's getting acidic. The body has a buffer system where it's going to be pumping sodium bicarbonate in it, or like a Tums. That's what essentially a Tum is, right? Or Alka-Seltzer has sodium bicarbonate and some other things to absorb the acid. So your body has a buffer system that's going to be pumping bicarbonate in there to absorb the acid. Y'all know this from chemistry, right? If you have an acid, then you have a bicarbonate, and you add those together, it weakens the acid, right? Remember that? So, when you look at DKA, I mean, and this is essentially above, DKA is usually above 500. They're saying, oh, you're 400 or 500 blood glucose. They're saying, oh, you could go into DKA. There's another one that's worse than this. It's called HINC, and I forget what all the words mean, but it deals with now your DKA, but it also deals with the concentration of fluid in the body. Osmolarity, I think it's called. So you start looking at it, ultramental status, dehydration, you get this fruity odor smell to it. It smells a lot like bourbon. So this is where a lot of people get off track. They think this guy's just drunk. He smells like a brewery. He smells like bourbon. And they get out of focus on thinking about diabetes. The police used to do this all the time. These guys would be stumbling around, walking around on the street. They'd lock them up for public intoxication, right? Go the next day and they'd be dead. Because they were diabetic. They weren't drunk, they were just diabetic. Now, they'll call you out at 3 o'clock in the morning, ask you to do a finger stick on them to see if they're diabetic or they're drunk. We call it a pre-incarceration diabetes. Because they get pulled over, they smell like alcohol, they're about to put them in jail, and the driver say, oh, I'm a diabetic. And so they're calling an ambulance out to check a D-stick. They're sitting there cuffed. You pull their hands out, you prick their finger, you check their blood sugar. Blood sugar normal, they go to jail. Blood sugar high, they go with you. You know, most of the time it's normal. They're just trying to get out of jail from it. But they produce these ketones, and it does. They look like they're intoxicated. They act like they're intoxicated. But they have an altered mental status. So if you follow that rule of always check a D-stick, right, then you don't have to worry about that. If the D-stick is normal, then they're more than likely intoxicated. Or you start sort of ruling those things out. A lot of the things deal with protocols, but always measure the blood glucose. Always look for the medications in the patient's home when you start your assessment process. This is a good chart. 60 to 80 It could be a little low, but the diabetics are on this weird thing. It's like blood pressure. It's what's normal for them. So, 80 seems low, but 100 would seem low if your normal blood sugar is 200, right? 100 would be low. So less than 50, usually you will get severe altered mental status. But I've seen patients with blood sugar 40, just alert and oriented too. So just depends. 200 to 300, then this is where, above 300 is where you get into the DKA. But 200, not that would be a normal hyperglycemia. On your glucometers, once you fall below 40, all they're going to say is low. Most of them will just say low. And once you go above, I think it is about 400 to 500, all they're going to say is high. So you know they're really low or they're really high when you look at the glucometers. But that's a good chart. So, there we go. Yeah, a lot of times you don't have to treat them with the oral glucose. If their blood sugar's low, they get hypoglycemia. If they're acting a little off, just have them eat something. But make sure what they eat, they can absorb that glucose fast. Like a Dr. Pepper, there's 26 flavors or whatever it is. 28, 26. 26, right? Mm-hmm. Really sweet. So they absorb that under the tongue, remember? Just like the nitrous sublingual under the tongue. You can get them to drink some orange juice or something that they're going to break down and leave it in their mouth. Let them just have them drink the soda or the juice or whatever. Have them hold it in their mouth for as long as they can to allow the body to absorb that sublingual. And it will work very quickly. And then just have them swallow. Chocolate and things of that nature takes too long to break down. What about hard candy? What's the problem with hard candy? Yeah. Possibility of they're becoming too altered in swallowing the hard candy and becoming airway obstruction. They make that gel candy and stuff. So there's a lot of things you could use to raise someone's blood sugar up real quick. Ice cream works great. If I ever have an altered mental status, just go to the cafeteria, get me some Bluebell. You don't have to just shove it down. That's okay. Even if I don't know what you're doing, that's fine. So before, the thing that's going to really sort of give you the big clue is they're going to have a history of diabetes. But before you give the oral glucose, remember it's a carbohydrate. You guys know that now because you've done your drug cards, right? So they have a history of diabetes. They have an altered mental status. Make sure that they're just awake enough to swallow it. And I always try to give it to the patient, have them self-administer the glucose, like this lady's doing here. She's sort of squeezing it in there. I still tell them to say, hey, hold that under your tongue. Don't swallow it. Just let it sit there under your tongue for a little bit. And try to get them to do that. It works faster that way. But if they can't understand you due to some altered mental status, then just let them swallow it. And they may need 2 tubes. What do you do if they take 1 tube and they go, oh, can I have another one of those? Wait a little bit, check their blood sugar. Probably wait 5 minutes or so, check their blood sugar. But more than likely, if they're asking you for another one, they still need another one. It's just the body's response. Have you ever been really thirsty and you got somewhere where there's water? Someone handed you a bottle of water, you drank that bottle of water down and you go, whew, I need another one. I need some more water, right? The glucose is the same way. They're sort of saying, I need this. That's why if we checked your glucose levels right now, and let's say pumped you full of ice cream later, Wouldn't that be cool? It really wouldn't fluctuate your blood sugar that much. We tried it a few years back. We didn't eat breakfast. The first year class didn't eat breakfast. Checked blood sugars. They were all normal. None of them were diabetics. We ate, rechecked their blood sugars, and it didn't really change that much because they weren't diabetics. They really didn't. They needed to eat, but they didn't need the blood sugar. They all had normal blood sugar levels. You'll see it the most if someone wants to take one for the team, not eat all day, come in, let's check your blood sugar, and then do the experiment. But with you guys eating throughout the day, it really wouldn't make that big of a difference.
I'll do it.
You do it? You just won't eat all day? Don't eat all weekend and come in, we'll do it.
You're funny.
Your reassessment is just to make sure you get a second D-stick level, make sure that they're improving. And again, a lot of times you won't transport these patients. You know, they'll be fine. Questions there? Any questions on diabetic emergencies?